think you make a very good point. Up until very recently, for decades and decades, our management of PV has been aspirin, hydroxyurea, and phlebotomy. We didn't have anything else. And so worrying about where the hematocrit is and symptoms and all these things, we didn't really have any other tools. People didn't want to use interferon, but there are better tolerated interferons, more data coming. And of course, now there's ruxolitinib. Serge, I'm going to turn to you to review the data for ruxolitinib in PV patients.
I think you set the stage very well, and only now we have a good reason to review our practice and see how well are we doing with hydroxyurea. So in retrospective chart review studies, a number of them have been done, 20 to 25% of the patients are not really benefiting and should be candidate for something else. And now we have opportunity to introduce ruxolitinib as a JAK1, JAK2 inhibitor that Ruben mentioned as alternative in these people who are not responding very well. So the two studies that led to its approval, first there was a response study and then a study called response 2, but they should be looked at together, really describe the value of ruxolitinib in this setting very well. The one study, response study, was for patients that did not do well on hydroxyurea and required phlebotomy and had a big spleen, and they were randomized between the ruxolitinib and control arm, which in majority of the cases was hydroxyurea itself, because that's the evidence of not having any or many other choices. The response 2 study was the copy of that study, so patients refractory resistant to hydroxyurea with the need for phlebotomy, but without the spleen. So the benefits are easy to understand. That was significant difference in ability to control the red blood cell count, not going to the numbers itself, but the majority of people had controlled hematocrit on ruxolitinib and minority on the control arms. And then in the study that requires big spleen, the spleen was significantly reduced with ruxolitinib and not with the control arm. And then when we look beyond just the red blood cell count and spleen, we also look at the control of the white cells and the platelets and the symptoms. This is how I look at the benefit of any therapy. 5 factors that are built in the guidelines what the response should be or how to assess the response, and that should be again control of the red blood cells, white cells, platelets, spleen, and symptoms. So we talk about primary goal, elimination of phlebotomy, normalizing the hematocrit below 45, controlling myeloproliferation that Dr. Shammo described, white cells and platelets to extent possible, but then for the quality of life issues, control the big spleen that may be symptomatic, and general systemic symptoms. So these are the benefits of the new therapies that we cherish, and ruxolitinib is now an option in second-line setting.
How often do you have to adjust the dose of the ruxolitinib? We start at 10 twice daily, and how do you do that? What do you use to adjust the dose?
Myelofibrosis, you are right. The starting dose for every PV patient is suggested to be 10 milligrams twice a day, and expectations are that you will go up. 65% of the patients needs to increase. So from 10, you go to 15 twice a day, then to 20 twice a day, and even some patients need 25 twice a day. And it's all adjusted based on the need to control that blood cell count and those symptoms that we described. Only about 5% of patients need less than 10 twice a day, and that would be because of too much of the myelosuppression. This is where we simplify things really for patients, looking at the numbers, because other non-hematological toxicities are very rare. There are some, but they're not very common. And the guidance really would be to look at the blood cell count, optimize the dose to derive those benefits on control of the symptoms, spleen, and blood cell count to the maximum.
Okay. Boy, I had a question at hand, but now it's escaped me. I'm going to move on to, oh, I know what it was. I know what it was. Ruben, I need your help on this. Okay, so yes, I see the data from the response trials showing superiority in terms of decreased in phlebotomy requirement, better erythroid control, reduction of splenic volume in response 1. But the goal of therapy here in PV is to prevent thrombotic events. Is there any evidence that by switching to ruxolitinib, you may actually prevent thrombotic events by doing this?
In short, yes. So the studies were not powered with thrombosis as a primary endpoint, but there clearly have been many fewer thrombotic events on the ruxolitinib arm versus the best alternative therapy arm. And there's good mechanistic reason to believe that that is true. First, better control of counts, more consistent control of counts, as well as likely improvement in inflammation and other aspects that might really create a pro-inflammatory milieu. I'm mindful that patients that are inadequately controlled, let's say with supplemental phlebotomies on other medical therapy, they're going to be spending a good amount of their time above the target hematocrit of 45. Because every time you phlebotomize them for their hematocrit of 49, how long have they been above 45? Maybe they've been above 45 since the last time you phlebotomized them. I mean, we don't know. So it's a very uneven sort of control of the hematocrit. So I think there's multiple mechanistic reasons why, stable control with a JAK inhibitor like ruxolitinib, is probably superior for thrombosis prophylaxis.
Christina, the primary endpoint of response was at 32 weeks, and we're talking about a disease that in patients who have very similar life expectancies to age and gender match control. So what do we know about long-term? Is there longer-term data from the response trials about tolerability and durability of these responses?
Absolutely. So we see that at 156 weeks that these responses, both hematologic, splenic, and symptom responses, were sustained, and patients maintained activity on the ruxolitinib. And so I think the response data certainly has given us another option to treat patients, particularly when they have had progressive disease on first-line therapy, and has been a very valuable contribution to our therapeutic armamentarium.